Hi, I'm Dr. Chris Saigal, Professor of Urology at the UCLA School of Medicine. In terms of prevalence, or how common is this problem, BPH is actually a diagnosis made by looking at the prostate tissue on a slide. And you can see many cells growing more than are normal. They're not cancer cells, they're just normal cells that are too numerous in quantity. And you can first see this happening at age 40 in men. By age 60, about half of the men show some evidence of this change in their prostate. This is probably due to the fact that the normal prostate has a balance of cells that are being created and destroyed. And as men age, for some reason, the older cells simply don't get destroyed. However, only about half of men who have changes that are consistent with BPH on a slide have symptoms. And because just having BPH as a histological or slide-based diagnosis doesn't mean you have symptoms, we really call these symptoms lower urinary tract symptoms, or LUTs, to capture the entire spectrum of people that have these problems. These are really common problems to see the doctor. This is a slide showing the number of office visits per 100,000 men for these kinds of problems. And you can see over time the bars have gone up, and basically if you look at the year 2000, about 7% of the visits to doctors' offices in the country were for a primary complaint of lower tract symptoms. And actually about 14% were for, it was one of the diagnoses a person was seeing the doctor for. So many men are seeing physicians for these complaints. But the question is, what are we treating? We talked about how BPH is a diagnosis on a slide. And men that have enlarged glands don't necessarily have symptoms. Some men have very small glands and have significant symptoms. So we're really kind of looking at patient-centered therapy. Whether the BPH or enlarged prostate gland or simply lower tract symptoms, the key is, what is a patient suffering from, and how can we reduce those symptoms with the lowest risk to the patient. We classify these symptoms as either irritative in nature or obstructive in nature. Irritative symptoms are like overactive bladder symptoms, so urgency, frequency. Obstructive symptoms are more straining to urinate, feeling of not completely emptying your bladder, having a weak stream. We can actually measure the impact of these symptoms using what's called the AUA symptom index. The AUA is the American Urologic Association, the professional society that covers urology. These are some questions from that index, but basically it asks you questions like, over the past month, how often have you found it hard to hold your urine? Over the past month, how often have you had a weak stream? These are questions you get asked. You answer the question with a series of numbers, and we give you a score. Are you mild, moderate, or severe? And we can use these scores to track your improvement after treatment or decide whether you should have treatment at all. In terms of how we diagnose these problems, the guidelines recommend, of course, a history and physical examination. Sometimes other general medical problems can mimic some of the symptoms that men come in with. Out-of-control diabetes, for example, can cause urinary frequency and increased urinary production. We do symptoms index score, as I just described in the previous slide, to see where the man is at baseline. A urinalysis is done to rule out infection. A PSA test can be done in men who are appropriate. PSA is a test done to screen for prostate cancer, and men that have more than 10-year life expectancy are generally screened for prostate cancer in this setting. It's very unusual for prostate cancer to present as symptoms of obstruction or irritation. Optional are tests for bladder cancer, or urine tests for bladder cancer, or determination if the person is having retention of urine, which is called a uroflow post-void residual test. It's an ultrasound test of the bladder. Other lab tests are not recommended. This is a slide that the AUA puts out to walk us through how to treat patients with BPH. And just to summarize it, at the top here, after the initial evaluation, patients that have refractory symptoms of a BPH or lower tract symptoms, that includes having a bladder stone because their bladder is not emptying, having recurrent urinary tract infections, having blood in the urine. The prostate can get very vascular as it grows bigger, and kind of like hemorrhoids, when you strain, you can actually have one of those small vessels break and have blood appear in the urine. Those kinds of symptoms are typically treated by surgery. For everybody else, we measure their symptom score, and for men who are having a low symptom score, we can, if they're basically mild symptoms, we can even just watch them over time and see if they'll need therapy later. Most men fall in the moderate to severe categories, and for those men, the first step is discussion of treatment options. And really, because the goal here is to improve symptoms, and it's the patient telling us how much these symptoms are impacting their life, we have to get from the patient what their goals of care are, what their values are, and the trade-offs that they would make to achieve specific benefits in their symptom improvement. So patients that have a desire for non-invasive therapy as medical, we'll discuss medical therapy in a minute. And for patients that are interested in invasive therapy, there are some new technologies that can reduce some of the risks of BPH care. Medical therapy for BPH, there's two types of medications used to treat it. One are classified as, they're called alpha blockers for short. There's lots of generics on the market now. There are also some trade names that are still available. They're all very similar in terms of their impact. They drop your symptom score by 4 to 6 points. That's usually enough to take a man from severe to moderate or moderate to mild symptoms. They can have side effects including dizziness in some men and a decreased volume of ejaculation in some men. Those side effects are reversible once you stop the medication. There's also a class of medications called 5-alpha reductase inhibitors. Those are medications, finasteride is one of them. Avodart is a trade name for the other one. Those also will reduce symptom scores more about 3 points on average. They take longer to take effect. They work by medically shrinking the prostate gland itself, and that takes some time to do, so 3 to 6 months to see a real impact there. Combining these medications has been shown to actually improve your chance of doing well over time. This is a large trial called the MTOPS trial that followed about 3,000 men for almost 5 years. What they found was that in men that had prostates bigger than 30 grams on a doctor's exam, that there's a 2/3 reduction in the decrease in progression, that is, your symptoms getting worse over time. There's also a reduction in the risk of being unable to avoid at all, which is an end-stage problem of BPH, and also a reduction of similar magnitude in needing surgery at 5 years. So for men with big glands, we can combine these medications, if they're willing, to reduce their chance of having problems later in life. Now onto treatments that are done from a surgical standpoint to reduce obstruction. There are some office-based procedures. Those are microwave energy-based, or also there's one called transurethral needle ablation, which is radiofrequency-based. They essentially heat prostate tissue and cause it to die and get resorbed by your body. They have the advantage of being done in the office to avoid an outpatient surgical experience or an inpatient surgical experience. They require sedation, though, because the catheter is placed into the bladder. This is a graphic showing you how this works. Basically, this is the prostate kind of cut in half, and the bladder's up here. This is a catheter going into the bladder, so urine would drain out here. And right here is a microwave antenna that heats the prostate internally. Over time, this tissue will die and get absorbed, and the prostate will shrink away. So some of the advantages, I mentioned that it's an office-based procedure that's convenient for some patients. However, there are higher retreatment rates generally observed with these two technologies. That is, a man will need a retreatment in 2 or 3 years. They are best done in men who have smaller glands, smaller than 60 grams, which is a doctor's determination. And they also can require a catheter in the bladder to remain for longer periods of time if a person has obstruction, as the tissue takes a while to absorb back in. So you can have a catheter in for a week or two sometimes after these procedures. The traditional surgical procedure, the gold standard, is called a TURP, or a transurethral resection of the prostate. This is done in the hospital, requires an inpatient stay for 2 to 3 days typically, with a catheter in, with the bladder being flushed with saline. And it does have standard risks, including the risk of transfusion, about 10%, a risk of infection in the bladder, perhaps 1 or 2%, what's something called TUR syndrome, where because during the surgery we use water to irrigate into the bladder so we can see, the water can be absorbed across the prostate and affect the electrolyte balance in the blood, which can cause changes in mental status. The chance that's perhaps 2 or 3%. Problems with ejaculation. This is a common side effect of all surgical treatments for BPH. The risk can be as high as 50% for men after surgery. They're able to have an erection and have an orgasm, but nothing comes out. There's also a risk of a scarring in the urethra, the tube that carries the urine through the penis. The risk of a stricture is about 4 or 5% over time. If that happens, it's opened up again in a second procedure. For men that have very small or very large prostates, there are some traditional options that are alternatives to this. The transurethral incision of the prostate is done for men that have small glands. This surgery is probably aimed at men that don't actually have BPH but have a very tight capsule of the prostate gland, and the muscle kind of tightens up and squeezes the channel shut. So remember, with small prostates, we can actually incise the prostate instead of carve away tissue, and that can relieve obstruction. There's a lower risk of problems with ejaculation after the surgery. Open prostatectomy is done. It's a major abdominal surgery done with an incision in the abdomen to remove benign tissue. It's done for people that have very large glands, bigger than 90 grams, and the average prostate is about 20 grams, so more than 4 times normal. That surgery is a 3 to 5 day stay in the hospital. There are higher risks of needing a blood transfusion, a longer recovery time, up to 4 weeks, and certainly effective, but definitely has higher risks. To reduce some of the risk of surgical therapy, 2 new technologies have become quite popular. One is photovaporization, or PVP. The other is bipolar plasma vaporization. And in general, when you vaporize tissue instead of carving it away, you have better control of bleeding. And that results in less need for transfusion and potentially an outpatient procedure. Photovaporization, using the laser, it heats up the red blood cells, and those red blood cells actually do rupture and explode and transfer heat to the tissue around it. The tissue vaporizes and seals blood vessels. This can be done using saline instead of water, which eliminates the risk of that TUR syndrome. The advantages of this surgery is that in the long term it has a very similar impact on symptom scores to the TURP procedure, and it has the ability to be done on very large glands, so you can do 90-gram glands with a laser because the risk of absorption of water is very low, or zero basically with this technology. You can also be doing this procedure on patients who have anticoagulation on board for whatever reason because of the enhanced control of bleeding with a laser. Disadvantages are similar to TURP. There's a risk of retrograde ejaculation at the same level. With larger glands, you can't see an increased risk for retreatment with a laser, and there are still the standard risks of scarring or stricture. You can see more overactive bladder symptoms after a photovaporization, which generally go away after 2 to 4 weeks, but some people have overactive bladder running to the bathroom, more urgency or frequency. Bipolar plasma vaporization is a procedure that has a similar benefit to laser ablation. It is potentially a shorter procedure with less irritative side effects, and I'll talk about that in a minute. Our next slide has a little bit of a visual on what these procedures look like. In this video, we're looking into the bladder through the urethra, and prostate tissue is on either side here blocking us. On the left, we have the TURP procedure, and we're actually carving away tissue. And what happens over time is you see little bleeding points there that begin to accumulate, and that's where the issue can happen in terms of needing a catheter and staying in the hospital. This is the laser, and we can see here there's bubbles coming out of where the surgeon's working. That's tissue being vaporized. And it's fairly bloodless. It does take longer, however, as you noticed. Bipolar plasma vaporization is similar to the laser. Here's a photo of how that looks. Basically, the element heats up and vaporizes tissue with bubbles. It's a very similar impact to the laser. The results of vaporization by either mean are pretty good and comparable to TURP. This is a picture of someone's the prostate gland kind of impinging on the urethra channel here. And 3 months after the surgery, it's wide open and healed up, and the patient can void without obstruction. In terms of comparing laser to plasma vaporization, there was one randomized trial in this area, and the plasma vaporization was associated with a shorter operative time and fewer post-operative voiding symptoms in terms of irritation and overactive bladder symptoms. On the horizon, which is not a usual technology we use right now, but has been studied in various centers, is Botox. Botox is currently being used for men that have primary overactive bladder or spastic bladder without any obstruction. It relaxes the bladder muscle. It can also be used for men that have obstruction in studies, and in that situation, the Botox is actually injected through the urethra under anesthesia into the prostate, and it causes the prostate tissue to shrink away for reasons that are actually not known. So that's under study as a potential way to go. In terms of ways to prevent your risk of developing BPH or perhaps improve your symptoms, there's a strong association between exercise and lower tract symptoms. This is the results. This is a big study combining the results of many studies, and what it shows is that for men who are the most active, there's a 25% reduction in their risk of having lower tract symptoms. This is a study from the US population looking at diabetes control, and what this shows is that for men who have the best diabetes control, they are about half of the risk of men who have the worst diabetes control in terms of their urinary symptomatology. So both exercise and good diabetes control can benefit men who are at risk for having problems with urination. So in conclusion, combination medical therapy with alpha blockers and 5-alpha reductase inhibitors can reduce your risk of needing surgery or getting retention and reduce your risk of getting worse over time. For patients who are interested in surgery, vaporization techniques may deliver the benefit of a TURP procedure without some of the risks. And most importantly, treatment decisions have to be personalized to the goals and values of the patient. There's no right answer that fits every man. The person's goals and lifestyle play a key role here. Thank you. We have some questions here. Should I just read these off? Okay, so from our audience, will a successful procedure produce an increase in semen production? No, it will not. The procedures themselves will have a risk of reducing semen production in terms of expelling it. So this procedure is not indicated for that problem. There are surgeries for that, but an infertility specialist could answer more questions about that. What are the statistics for adverse effects and bad outcomes for TURP and laser procedures? So I talked about some of them in my lecture. The overall risk of need for blood transfusion after a TURP is perhaps 10%. After a laser, it's on the order of 1%. Retrograde ejaculation, the problem with ejaculation is about 50%. That happens in both surgeries, as does stricture, which happens about 5% of the time in both types of surgeries. How long will I be out of work for typical prostate surgery done with the newer technologies? So these technologies are typically done if a person is healthy as an outpatient, and you go home with a urinary catheter in, and that catheter is removed after 1 or 2 days when the urine is perfectly clear. So you'll probably be off of work for 1 to 3 days, and you should be able to go back to work right after that. If you have a very physical job, you might take a week of light duty. What is recovery like? So as I mentioned, for the new technologies, typically you go home with a catheter, and that's removed after a day or two. There's no bodily pain except for the catheter, which can be irritating for some men. When the catheter comes out with the laser, and certainly sometimes with the electrovaporization, you can have overactive bladder symptoms for a period of time as your bladder kind of recalibrates to the fact that there's not an obstruction anymore. It's usually squeezing hard to get the urine out. When the blockage is gone, it just keeps squeezing hard, and you have that sensation you've got to go to the restroom urgently. You can have intermittent blood in the urine from these procedures for up to 2 months. It goes away on its own most typically. Are there any risks to putting off the surgery? It depends. If you're in a situation where you're having kidney dysfunction, your kidneys are blocked, or you have a bladder stone, or you're having recurrent bladder infections or blood in the urine, your health can suffer if you wait in terms of worsening renal function, in terms of the risk of a serious infection from a bladder infection, the risk of a transfusion if you have a heavy bleeding event. If you're a more typical patient with just moderate symptoms, deciding to have treatment is really about when you're sick of taking medications or the medications aren't achieving your goals and the risks of surgery make sense to you. For some men who are retaining urine where they can't empty properly and they are having a lot of urgency and they still can't get the urine out, those men are at risk for their bladder, I think, starting to decompensate. As it works really hard, if it gets overworked, the bladder can actually lose its muscular tone and become more fibrous. And at that point, even if you remove the obstruction from the prostate, the bladder doesn't squeeze as well, and you still have retention and bladder symptoms that have to be treated sometimes with a catheter. So I'd say for men that have obstruction and poor emptying and bad urgency symptoms, that waiting can make the bladder less likely to work well after a surgery if you do it. Does having an enlarged prostate gland mean you're more likely to have prostate cancer? I'm glad someone asked that question. The answer is no. They're totally separate diagnoses. And prostate cancer is usually diagnosed with a PSA test. If it's elevated, you're at risk. But also benign prostate tissue makes more PSA. So both types of conditions can result in an elevated PSA, and your doctor can help you sort out what's going on with you. sometimes with the help of a prostate biopsy. But they are separate in terms of their origin and their impact on the person's health. And how can I decide what the right treatment is for me, and when should I consider surgery? Well, again, this is all about shared decision making. There's a lot of information on the web, but a lot of it is marketing oriented. Hopefully this webinar was helpful in understanding some of the risks and benefits of the common options. I think it's important that you have a doctor who records where your symptoms are now and listens to your goals of care and tries to personalize care with you and make sure you have an educated decision. All the questions? All right, thank you very much.